Moving on to the next session. To chair this session, we have with us Dr. Kuchela Babu, Dr. Lalita Mehedrata, Dr. Bhala Bande, and Dr. Thampi Matthew, and Dr. Dibendra Tripathi. And in this session, we have Dr. Bhavani Shankar Kodali and Philip Hathron as the speaker. To begin with, we have Dr. Bhavani Shankar Kodali. Dr. Bhavani Shankar Kodali will be talking on the topic Capnography, Where Are We Now? Capnography, Where Are We Now? By Dr. Bhavani Shankar Kodali.
Good morning or good evening, depending upon the time you are going to view this video. Today, I'm going to talk about capnography. Where are we after 3 decades of its introduction into clinical practice? Here, I'm also going to recap some underlying physiology of capnography. Now, the goals of this lecture are 4. Recap some notable developments in these 3 decades of capnography. How and where did capnography find applications beyond the 4 walls of operating room? Understand the physiological basis of these applications and interpretation of capnography under some unusual circumstances. The 3 underlying physiological concepts one should always remember about capnography are: capnogram is not a line diagram, but it is a visual representation of BQ mismatching of the line, the end results of Riley's 3-compartment model in the lung. Number 2, the alveolar plateau has an end-tidal CO2 somewhere embedded in the phase 3 or the alveolar plateau of CO2 curve. We do not know exactly where on the plateau is the end-tidal CO2. The third is I will talk about volume capnography because it is opening up of a new era of determining Bohr's physiological dead space. Now, if you look at the overview of capnography, this is the anesthesia circuit in the operating room with the ventilator and the breathing circuit, and this is the patient circuit, and in between these 2 circuits is a critical junction of the airway or the endotracheal tube, and this is where we measure capnography or we use capnography. Therefore, when you are monitoring CO2 at this critical junction, it gives you the entire perspective of the anesthesia circuit on one side. It also gives an entire perspective on the patient's ride, right from the metabolism and CO2 production of carbon dioxide, its transport via heart to the lungs, and elimination from the lungs and into the anesthesia circuit. Capnography is not a direct monitor. That means it is not going to tell us straight away what is the cause of an abnormality. Rather, the clinician should have sufficient knowledge to interpret the clinical circumstances and come to a reasonable conclusion of the etiology of an abnormality in capnography. Now, when you look at the landmarks in the last 3 decades, there are a lot of changes that have happened in the terminology of capnography, capnography in pregnant subjects, capnography during laparoscopic surgery in pregnancy, pediatric capnograms, and Outside of the operating room, particularly the CPR, the procedural sedation, intensive care units, transport of patients within the hospitals and in between the hospitals, and post-operative management. And so these are some of the landmarks that have taken or the landmark developments in capnography in last 30 years. Now, when you look at the nomenclature of capnograms, in the past, there are several nomenclatures were used to demonstrate the various phases of capnogram. PQRS, ABCD, etc. But in 1995, we came up with a standard terminology for capnography or for capnograms, namely an expiratory segment and the inspiratory segment, and phase 1, phase 2, phase 3. Phase 1 is the dead space gases. Phase 2 is the dead space to alveolar gases. It's a transition from dead space to alveolar gases. And phase 3 predominantly represents the alveolar gases. And when the next breath starts, the CO2 concentration decreases to baseline, which is 0. And this is called as the phase 0 or the inspiration. The angle between phase 2 and 3 is the alpha angle, and this gives you an idea about the ventilation perfusion matching of the lung, because the alveolar plateau represents the CO2 evolution from the alveoli with various VQ ratios. And the beta angle between the phase 3 and the downward stroke represents an idea of any rebreathing. If there is no rebreathing, the angle is almost 90 degrees. Now, where does expiration end on that alveolar plateau, particularly in a time capnogram? Now, there are two capnograms here. One capnogram you can see here, which looks like a very normal looking capnogram. And this looks like a capnogram with a very prolonged expiratory plateau. We assume that the expiration ended somewhere here with the end tidal CO2, and this is the inspiratory phase here. Whereas in this capnogram, where is the end tidal CO2, or where did expiration end? And this is going to be very difficult to find out on a time capnogram. Now, because in a normal capnogram, when you take the next inspiration, the CO2 concentration decreases dramatically. Whereas when the expiration is prolonged, particularly when the respiratory rate is slow, we really do not know where the expiration has actually ended, and the remaining is the end expiratory pause. For example, as shown in this capnogram here. Now, normally when the lungs empty out, there are fast alveoli and slow alveoli. The slow alveoli empty gradually, as seen by this green line, and the fast alveoli, they empty out rapidly initially and then slow down towards the end of expiration. Combination of slow and fast alveoli gives you the alveolar plateau. Now, generally, most of the expiratory gases flow out during the 1/3 of the expiratory time. That means the gases rapidly empty out of the lung. So in this capnogram, probably the lungs must have expired somewhere here or here, and the remaining is all end expiratory plateau. But we cannot normally make out where expiration ends in a normal time capnogram as is used currently. This is the expiratory plateau, and as you can see, particularly when there's a respiratory rate is slow, you can actually see some wavy waveforms towards the end, and these actually represents the pulsations from the beating heart, where the CO2 is actually moving back and forth within the airway and the sensor. Now, these are the two capnograms which I have shown here. Now, if you plot the expiratory flow and inspiratory flow and superimpose them on these time capnograms, this is how it looks. As you can see, this is where the expiration ended and the inspiration started. So it looks like in a normal capnogram. Whereas here, this capnogram also looks normal. But however, when you superimpose the respiratory flows on top of this, the expiration has ended here and inspiration has started here. So that means this point, this is where the end expiratory CO2 is, and the remaining is all the rebreathing because it is in the inspiratory phase. This is probably because of malfunction of the inspiratory or expiratory valves. So plotting the flows, the respiratory flows over the capnogram actually makes a lot of physiological sense while interpreting capnograms. Now, this is a capnogram where you can see this is the expiratory plateau and there is a sudden dip. This is because of the forward flow during inspiration from the ventilator, which is actually diluting the expired gases. So the expiration probably must have ended here. This is the expiratory plateau probably, or the expiratory pause, and during which time it is diluted by the forward flow during next inspiration, giving rise to this variety of capnogram. Now, what about capnography in pregnant patients? Normally, the end tidal CO2 is below the arterial CO2 by about 5 millimeters, which we call it as arterial to end tidal CO2 difference in non-pregnant subjects. In healthy subjects is about 5 millimeters. However, during pregnancy, this difference is narrowed to almost 0 or to 1 millimeters. And we did a couple of studies way back in 1986 and 87, where we measured the arterial to end tidal CO2 difference during cesarean sections and found this difference to be 0 to 1 millimeter. And this is of particular value because during cesarean section anesthesia, we can, if you maintain the end tidal CO2 around 32 millimeters, the expected arterial CO2 would be around 32 millimeters. Whereas if you follow the non-subject rule, where the difference is 5 millimeters, if you bring your end tidal CO2 to 28, then your arterial CO2 will be also 28, which is not good for the uterine blood flow because the uterine blood flow begins to decrease when the arterial CO2 decreases below 28. Therefore, these studies highlight that since the arterial to end tidal CO2 difference is 0 to 1 millimeter in pregnancy, it is necessary that we maintain the end tidals around 32 during cesarean section anesthesia. We also did a couple of studies measuring the physiological dead space during cesarean section, and what we found was the alveolar dead space is actually decreased during anesthesia for cesarean section. Now, another landmark observations were the arterial to end tidal CO2 difference during laparoscopic surgery in pregnancy. As we all know that we do many cases of laparoscopic surgery, particularly the cholecystectomy during pregnancy, and we are insufflating CO2 into the abdomen. During insufflation and anesthesia. Now, initially, based on the animal studies, particularly the pregnant ewes, an arterial line was advised during surgery, during laparoscopic surgery in pregnancy because of the fear of respiratory acidosis. However, subsequently, when we did a human study where we actually measured the arterial to end-tidal CO2 difference during laparoscopic surgery in pregnant women, we found that this difference is generally between around 1 to 2 millimeters, and therefore maintaining end-tidal CO2 around 32 millimeters is sufficient enough for us to know that the arterial CO2 is around 32 to 34 millimeters of mercury, and therefore an arterial line probably is not required, at least based on this study. Now, what about pediatric capnograms? Normally, you can get this variety of shapes of capnograms in pediatric and pediatric population and infants and children. They may look like this, they may look like this, they may look like this, they may look like this. This is because of the response time of the currently available monitors may not match the faster respiratory rates and low tidal volumes. However, the new technologies of capnography have made this possible to get normal capnograms even in small neonates with a very small tidal volumes because of a better response time of the analyzers, particularly the microstream technology with an aspiration flow rate of 50 ml from the airways is a good addition to our armamentarium. So the point here is the newer monitors that are currently available in the market that are very, very suitable for measuring CO2 waveforms accurately, even in very small children with small tidal volumes and faster respiratory rates. So these are some of the landmarks that have happened in the anesthesia-related areas of capnography. Now, these are the other areas where capnography has become popular, particularly the CPR, procedural sedation, intensive care unit, post-operative pain management, and transport of patients. And all these categories, they come under the capnography outside the operating room. So the capnography has spread from the operating rooms to all these areas around the operating room. And that is why you see capnography being used in the emergency department, during endoscopy, during angiography, and in the cath labs during sedation. Now, I did write an article on capnography outside the operating rooms for anesthesiology, for the journal Anesthesiology, and this is a free download, and I encourage all of you to read this article on capnography outside the operating rooms. Now, if you look at the ACLS algorithm for CPR, capnography has been strongly recommended and introduced into the current ACLS guidelines. Now, if you look at, or if you understand the physiology of capnography, as you know that the lung has got varying VQ ratios with a varying CO2 concentrations because of the varying VQ ratios. When these gases are expired out and measured, you get the typical alveolar plateau as shown here. The height of the CO2 curve is dependent on the ventilation and perfusion, and of course on the ventilation perfusion matching in the lung. So the height of the capnogram is very, very dependent on the cardiac output for a given ventilation. This is the principle that is used in capnography in CPR. This picture actually demonstrates the relationship between CO2 values and the cardiac output. A cardiac output of 2 liters generally corresponds to an end tidal of about 20 millimeters, and a cardiac output of 4 to 5 liters will correspond to an end tidal of 32 to 36 millimeters of mercury, provided the ventilation is normal for a given patient. And an abrupt decrease in end-tidal CO2 for a given ventilation suggests probably a drop in cardiac output if your monitoring device is performing well. Now, this is an example where the end-tidal CO2 is about 37 millimeters and with a cardiac output of 5 millimeters during surgery, and there is a sudden hemorrhage from the liver because of liver resection, and the cardiac output decreases, the end-tidal CO2 decreases for a given ventilation. So this is an example. And if we do not take corrective measures here, this is going to lead to a disaster as shown in this diagrammatic picture. Now, when there is a cardiac arrest during the case and subsequently it is revised, a trend capnogram actually looks something like this. The end-tidal CO2 decreases because the cardiac output is decreasing. Then there is a cardiac arrest. We are resuscitating the patient here, and the cardiac output gradually increases because after successful resuscitation, and the end-tidal CO2 increases gradually to normal with normalization of cardiac output. And this is the principle that is used in CPR. Capnography acts as a rescue device in CPR, and it helps to pull the patient from the death valley. Capnography has been demonstrated to be the most reliable method of confirming and monitoring correct placement of endotracheal tube. If there is no CO2 waveform during CPR, we have to rule out an esophageal intubation because the chest compressions produce a cardiac output, adequate cardiac output that can actually produce CO2 blips on the capnograph waveform. Because as I said, that a 2 liters of cardiac output generally should produce the CO2 waveforms of 20 millimeters of mercury. And 2 liters is the normal cardiac output that is expected during a CPR. Now, in England, what they have done is they have advocated the use of capnography for all CPRs because the coroner actually found esophageal intubation during CPR, and they actually advertised to all their members that esophageal intubation undetected because capnography is not used is now labeled a never event in the National Health Service in the United Kingdom, with capnography being mandated to be used during CPR. So it is a good step to enhance the safety of patients during cardiac arrest. Now, if you do a good chest compression and with an effective and produces an effective CPR and generating about 2 liters of cardiac output, the end-tidal CO2 should be around 10 to 20 millimeters of mercury or even greater than 20 millimeters of mercury. If the end-tidal CO2 values measured after initiation of ACLS are less than 10 millimeters, despite doing a good CPR technique, then it is associated with poor prognosis. And again, I'm emphasizing that how cardiac output is directly related to CO2. When CPR is being administered and there is a sudden return of spontaneous circulation, the cardiac output increases. And as shown in the earlier diagram or the earlier animation, there is a sudden increase of CO2. And this indicates return of spontaneous circulation. So this is another advantage of using capnography during CPR. We know when spontaneous heartbeat has started with good cardiac output. And that is the reason why many institutions, when they go for code outside of the operating room, they carry the capnograph so that we can measure the CO2 waveforms during resuscitation. And of course, we can also add a video laryngoscope because we do not know which patient is going to have difficult intubation during CPR. This is a very interesting case report where this person suffered a cardiac arrest and was resuscitated in the supermarket. They administered several shocks, and they initially thought that he was not going to be resuscitated because the heart never started despite continuing CPR and with shocks. However, one of the nurses who came to resuscitate this patient has substantial knowledge about capnography, and she realized that when they measured CO2 during resuscitation, the end tidals were consistently around 25 millimeters. When she called the physicians from in the emergency room and seek their advice, they said if the end tidals are pretty good, continue resuscitation, and they were able to give several shocks. I think about 13th or 14th shock, the patient's heart is revived after 96 minutes, and he goes to the hospital and gets an angiography and a big plaque removed from the coronaries, and he makes a very good recovery with neurologically intact. And this was one of the news in the television channels. And there they said, capnography, it measures how much carbon dioxide is being expelled from each breath. The information helps doctors and emergency medical personnel determine whether a patient is hyperventilating or having a heart attack in a layman terms. It also helps them to decide how to treat an asthmatic attack. And this is important because the CO2 waveform is abnormal during asthma, as we know, and to determine whether CPR is working. Remember, this is a public forum news channel on capnography, on the value of capnography. Now, when do you stop CPR? Well, in that case, it was 96 minutes. It is still uncertain presently, but however, capnography during CPR is actually being used as a prognostic value in determining whether patients should be cooled after resuscitation from CPR. Now, what about sedation and capnography? Now, in about 211 or so, the ASA and Association of Anesthetists of Great Britain and Ireland revised their standards and included that capnography should be used to monitor patients during procedural sedation, particularly during moderate and deep sedation. And subsequently, many societies across the world, as shown in this slide, have actually followed the suit and implemented capnography in their armamentarium during sedation. And this is a small brochure from England, and where it says that using capnography for all anesthetist-led sedation to improve patient safety. Capnography, the monitoring of carbon dioxide in the breath, is used to monitor patients' breathing and is the only way to make sure patients are breathing adequately while they are asleep or sedated. So this has changed our philosophy, and we all use capnography now during sedation, not only in the operating room, but outside the operating rooms. Now, why was this introduced? It is introduced because of 6 reasons. It is difficult to predict how an individual will respond to an administered sedation. We know as anesthesiologists and sedation providers. Incidence of hypoxia is less if capnography was used to monitor ventilation, based on some studies. Capnography, when used in conjunction with pulse oximetry and visual inspection of the chest, detected respiratory depression 17 times more often than without capnography. Capnography forewarns of impending hypoxia by about 5 to 240 seconds. So it is almost like 4 minutes. It gives you a warning that if you are not going to implement corrective steps, the patient may become hypoxic. Capnography triggers an early intervention and decreases the incidence of oxygen desaturation. And this is no brainer. As anesthesiologists, we see this all the time. And administration of supplemental oxygen delays the onset of desaturation following apnea. And therefore, relying on pulse oximetry alone will delay intervention. And this is one of the important points to remember when you administer oxygen during sedation. Now, we all know that when you are administering oxygen and then measuring the CO2, your CO2 waveforms may look abnormal, but that is fine. These are the baseline capnograms. What is important is a change from the baseline. As you can see here, probably the respiratory rate has decreased because of sedation. And in this capnogram, the height of the CO2 waveform has decreased because of hypoventilation or probably respiratory obstruction. So what is important during sedation is a change from the baseline to during sedation. Now, when I monitor CO2, what I generally do is I put a nasal cannula, as you can see from this red arrow, to monitor CO2 alone and put an oxygen mask. And you see how normal looking capnograms you get. And I actually make a small hole in the mask so that the endoscope can be introduced through that hole and the procedure can be done. And your capnograms are more or less, they look normal. This is a differential diagnosis of capnography during sedation. This is an algorithm. And if you go to my website, capnography.com, and go under sedation, you can find this algorithm and you can study this algorithm and how to use capnography during sedation. Now, what about capnography in ICUs? A landmark study which is the National Audit Project, or what we call as NAP4, by the Royal College of Anesthetists and Difficult Airway Society, determined that a major complication of airway, they studied the major complications of airways in 3 places: the operating room, the emergency department, and the ICU. During anesthesia, there were 16 airway-related deaths in 3 million anesthetics monitored with capnography. So it is 1 in 180,000. In the ICU, there were 18 airway-related deaths in 48,000 patients receiving ventilation. And the incidence is 1 in 2,700. And this is an important thing. 74% of the incidents were considered preventable with continuous capnography. If you go back to 30 years before the introduction of capnography, similar statement was made. When they did the ASA closed claim analysis, they said that probably about 70% of incidents could have, brain deaths or the hypoxic events could have been prevented with continuous capnography. So a similar finding also has been demonstrated in the ICU. Therefore, they advocated the use of capnography from 25%, which was at that time 25% of the ICUs used capnography during that time. They wanted to increase it to 100% because the risk of encountering a major airway complication in ICU is about 66 times more often than in the operating room. And that is why capnography was recommended to be used in all ICUs. And particularly, as we know, majority of the cardiac arrests in an institution or a hospital occur in the ICUs. And I just explained how capnography is a useful tool during CPR. So the national air, so this NAC4 study, what were their final conclusions are the capnography should be used in all patients for intubation irrespective of location. Routine use of continuous capnography in all intubated patients or with tracheostomy. If not used, state clinical reason. Train all staff in identification of abnormal waveforms. As I said, capnography requires certain amount of understanding for proper interpretation and use in clinical practice. Checklist of intubation and tracheostomy preparation, equipment, drugs, etc. Of course, all this checklist is also required. So these are some of the recommendations they came up. And they also said that it will take a couple of years for the implementation of capnography across all ICUs in United Kingdom. But now what I understand is the use of capnography is almost 100% in United Kingdom. Now, volume capnography and Bohr's physiological dead space. Now, we all know that Bohr's initial physiological dead space calculation was the alveolar PCO2 minus expired PCO2 by alveolar PCO2, and roughly is about 0.3. Now, since it is difficult to determine alveolar PCO2 because it needed an extensive methodology using Douglas bag, Enghoff modified it and he supplemented the alveolar PaCO2 or the alveolar PCO2 with arterial PCO2. And this is what we have been using all these years, probably for a century now. However, with the advent of volume capnogram, we are able to actually determine all the components of a tidal volume, namely the effective ventilation, this is the physiological dead space, the components being anatomical dead space and alveolar dead space. And somewhere on this alveolar plateau is the mean alveolar PCO2. And volume capnography is able to give us this value of mean alveolar PCO2. And therefore, now actually we are in a position to determine the original Bohr's physiological dead space breath to breath during ventilation. Since Bohr's physiological approach uses the alveolar PCO2, it is slightly smaller than the Enghoff's approach because it uses PaCO2. Because the arterial CO2 not only takes into the effect the dead space, but it also takes into the effect, effectively it takes into effect the shunt fraction also. So, Bohr versus Enghoff's physiological dead space, what are the major points? In Bohr's physiological dead space, we use alveolar PCO2, whereas in Enghoff's modification, we use arterial PCO2. Here we use the CO2 from the alveolar side of the alveolar capillary membrane, whereas here the CO2 is used from the mixed blood from the alveoli. So it is the other side of the alveolar capillary membrane. Bohr's physiological dead space is before the effects of shunt and the venous admixture on PaCO2. Here, it is after the effects of shunt and venous admixture in Enghoff's modification. So Bohr's dead space is an index of true dead space, whereas the Enghoff's modification of Bohr's dead space is a true dead space, as well as any condition that contributes to the elevated PaCO2, such as a shunt fraction or any condition where the CO2 is elevated and is not accompanied by an increase in CO2 elimination. The Bohr's physiological dead space is affected by high tidal volume and of course P, and it is also affected by hypovolemia or pulmonary embolism. So these are some of the important characteristic features of Bohr versus Enghoff's physiological dead space. Now, when you measure both during a clinical scenario, when the PaO2 by FiO2 ratio is decreases, then there is a widening of Bohr's and Enghoff's values. That means there is a greater deviation from these two values whenever the PaO2 by FiO2 ratio is smaller. And this is a very important information for us in our ICU critical care patients. So what are the advantages of simultaneously determining both dead spaces in critically ill patients with high VD by VT? It's a useful complementary information, determines the effect of shunt and the VQ inequality versus true dead space in a critically ill patient. Bohr's dead space could be monitored continuously without breath gases using volume capnography. And the difference between the two helps us to gauge the progress of the recovery in a given patient. That is why now there is a thrust to use Bohr's physiological dead space being determined non-invasively with volume capnography in intensive care patients. Actually, this is a small device which actually measures the volume capnography, which actually gives you a volume capnography with all its components. And remember, and this device is very interesting. This is a side stream capnography. Actually, most of the volume capnography devices are mainstream, whereas this is a side stream capnography which has been tailored to give these values. As you can see, it gives you the CO2 waveform. It is also plotting the respiratory flows, which I alluded to, when we were talking about the way, where the expiration actually ends in a capnogram. And it gives you all the values of physiological dead space. And it also plots the CO2 concentration against expired volume, giving you the volume capnogram. So we have a time capnogram, we have a volume capnogram with all its components of physiological dead space. And it also gives you the flow volume loops at the same time. And it gives you additional information about the Fowler's dead space, the Cummings dead space, and also the Bohr's dead space and Bohr's and Enghoff's modification of Bohr's dead space. So nowadays these devices are coming into our clinical practice, where we can actually measure the components of physiological dead space non-invasively, breath by breath, in the ICU patients. And there are several studies in literature where the Bohr and Enghoff's dead space equations have been used in mechanically ventilated patients in children, and also even in patients with respiratory distress syndrome. What about capnography in neonatology resuscitation? In a study of attempted intubations in neonates, capnography identified all 40 tracheal intubations correctly and all 11 esophageal intubations with 100% accuracy. And it is very critical that that we intubate the newborns correctly in order to have good resuscitation outcome. And that is the reason some of the neonatology units have already started using capnography during neonatal resuscitation, and also continuously monitoring ventilation in the neonatal ICUs. Now, postoperative analgesia and sedation is a very important aspect of our clinical management. We all know that untoward postoperative respiratory depression has produced even deaths in some patients. As you can see, these are some of the patients who died postoperatively because of postoperative pain management with narcotics and sedatives. So there is a thrust and some recommendations to use capnography during post-operation, during post-operative period to monitor ventilation. And this is, in this study, basically they used capnography and they were able to detect some of the respiratory events, and that led to the calling of the rapid response team during post-operative period. So it's just to show that it is necessary to monitor ventilation in post-operative patients, particularly when they are getting narcotic agents. And capnography is one of the modalities that has been suggested for this arena. And the last one is, of course, the transport of patient. Now, capnography is essential to monitor not only ventilation, but the cardiac output during transport of patients within the hospital and from hospital to hospital. And many institutions, they use capnography. In fact, many states in United States mandate the use of capnography by the ambulances or the first care providers in the field area too. So they are actually taking full advantage of capnography, not only during intubation, but also transport to the emergency departments and other institutions. So these are the various landmarks that has occurred in capnography in the last 3 decades. And what is the future of capnography? The use of capnography outside the operating room will increase tremendously. Physicians from other specialties are exploring the value of capnography at rest and exercise in patients with heart failure, whether it is a sensitive device to determine if the patient has got a heart failure. Substantial training of physicians and nurses and the respiratory therapists will be needed if we are going to implement capnography across. Manufacturers need to provide reliable, cost-effective, and portable units capable of quick display. And capnography should be a default in all ICU ventilators, because I just showed you what are the advantages of capnography in ICU patients. And ICU training, because particularly in the ICU, training is required to prevent contamination of the senses. Because what happens is, the sensors get contaminated with the water vapor and secretions. But however, if you follow certain logistical processes, you can actually minimize the contamination and blockage of the side stream tubes of the side stream capnography. Anesthesiologists should be the forerunners in helping to deploy capnography outside the operating rooms. Because in an institution, anesthesiologists probably have substantial knowledge of capnography because they use capnography in the operating rooms as a standard of care in every patient. And therefore, we are in a better state to help the institutions to implement capnography across all areas, particularly the sedation providing areas in an institution, to enhance the patient's safety during procedures. Thank you.
Thank you, sir, for that wonderful session by Dr. Bhavani Shankar, sir. So we'll be moving on to the next session by Dr. Philip Hathron. So the next session is by Dr. Philip Hathron. So he'll be talking on physical principles of cardiovascular monitoring in anesthesia. Physical principle of cardiovascular monitoring in anesthesia by Dr. Philip Hathron.
Well, good morning, ladies and gentlemen. I've been asked to talk about the principles of cardiovascular measurement. So this is going to be a very quick overview. We've only got 25 minutes of the basic physics behind some of the measurement parameters that we routinely deal with. And I want to start by just a quick review of the basic measurement units. We are all probably now familiar with the SI system of measurement. There are 7 fundamental units, 3 of which are from the old Newtonian system, length, mass, and time, and then the more modern ones of electric current, temperature, substance, that's the mole, and luminous intensity. But the 3 basic ones remain in what used to be called the MKS system, so you've mass, length, and time. And from all these fundamental units, we can derive all of the other ones. So the cardiovascular parameters that I want to look at would be blood pressure, which is ubiquitous. I mean, we measure blood pressure so often and has been measured for a very long time now in medicine. Blood flow, which is quite difficult to measure, and cardiac output and stroke volume, which are very related to blood flow, which is why I'm sort of putting them together like that. Let's look at pressure and define pressure. Well, pressure is defined as force per unit area. And of course, Newton tells us from P equals ma, that old school equation, that force is mass times acceleration. So why can we use a length like millimeters or centimeters of liquid as valid units of pressure? Of course we do, particularly in medicine. We're very familiar with millimeters of mercury. Well, that's because we know the density of the liquid. And if we know the height of the column of that liquid, that's the millimeters, we can exclude the area in order to get the volume, because we're going to be dividing it by area in order to get the pressure. So ultimately it comes down to the mass, which is related to the volume, related to the height, and the cross-sectional area, and related to the force of gravity and the density. Therefore, if we specify the liquid, it only remains to specify the height to give us the pressure. Okay, non-invasive blood pressure measurement is a simple enough concept. You apply a known pressure to the vessel with an external cuff until the blood flow is stopped, and then you release it until the blood flow begins again. The question is, how do you detect that blood flow has begun again? And traditionally that has been by the Korotkov sounds, either that or palpation at the wrist, if you're really pushed and you haven't got a stethoscope, or oscillotonometry, which is basically a mechanical way of listening to the Korotkov sounds. Non-invasive blood pressure measurement, of course, is simple, it's cheap, it's non-invasive, it's the kind of thing you can carry around with you as GPs would, but it's pretty prone to intra-user and intra-user, for that matter, variation, and a fairly wide interpretation of the Korotkov sounds. Even today, there's some debate as to what each of the sounds actually signifies. And it's also affected quite markedly by a mismatch of the cuff to the arm. If the cuff's too big, too loose, if the patient has serious arrhythmias, and particularly in the case of sclerotic arteries, where if you think about it, if you've got a very rigid artery, it will take an enormous pressure to occlude that artery, far higher than the pressure in the artery itself. Von Recklinghausen recognized the difficulty that people had with detecting and interpreting the Korotkov sounds, and he refined the technique with the oscillotonometer, which basically used a second cuff attached to a mechanical system of gearing, which amplified the vibrations, the pulses produced by the Korotkov, or rather, which give rise to the Korotkov sounds, and this greatly improved the accuracy of the technique. Automated non-invasive blood pressure monitors such as the Dynamap use the same basic principles of oscillotonometry. replacing the needle on the dial of the oscillatory tonometer with some modern electronics. All right. We're really more interested today in invasive pressure measurement and how that is done. So this technique measures the pressure in the artery directly, or in the vein, or a heart chamber, or CSF, or indeed anywhere within the body that we have a pressure, we have a liquid under pressure. It's not as operator dependent as the non-invasive systems, except that you have to be able to insert a cannula or insert a catheter. And its big advantage is that it can measure beat-to-beat pressure variation and provide a diagnostic waveform as well as absolute values. And it's continuous. If you think of the non-invasive, the automatic non-invasive pressure cuffs, many of them are designed not to be able to allow you to inflate the cuff more often than 1 or 2 minutes at a time to prevent ischemia. But invasive pressure measurement gives you continuous beat-to-beat pressure measurement. And the basic physics principle involved in all of this is that liquids are incompressible. Physicists and engineers will tell you that that's not strictly true, but as far as we are concerned in physiology, with the pressures involved, liquids are incompressible. So if you have a pressure wave arising at point A at one end of a tube, it will be transmitted via the liquid to point B. There are obviously real-world applications for this very principle. The brakes in your car, certainly older clutch systems in the car, hydraulic rams, all sorts of things rely on the fact that liquids are incompressible. So having got a pressure wave transmitted through a tube, we need to do something with it. We need to be able to measure the pressure variations. And for that, we use a transducer, which converts, in broad terms, one form of energy into another. In our case, we're talking about mechanical energy into electrical energy, or at least into some semblance of electrical energy that not actually producing a voltage. Transducers are pretty common in everyday life. The microphone I'm using at the moment, the loudspeaker or headphones with which you're listening to this are both examples of transducers. So how does the transducer work? Well, the microphone, the loudspeaker, pickup cartridge and a record player, and many others use a variety of techniques, but for blood pressure measurement, it tends to be down to the strain gauge. So we're going to look now at what a strain gauge looks like, or how it works, and what its physical principle is. And we need to be reasonably familiar with Ohm's law here. If you remember that Ohm's law states that voltage, current, and resistance are interdependent, that if you hold the voltage constant and change the resistance, that the current changes. So if you have a piece of wire and you stretch it, then the resistance increases as the wire becomes longer and thinner. That's a simplistic way of looking at it, but that isn't in practice what happens. Now, an ordinary piece of wire doesn't change very much in terms of its resistance. But if we had a piece of wire or a piece of very thin foil of a particular kind of metal laid out in a zigzag pattern on a diaphragm, and we stretch or deform the diaphragm, then the foil pattern will change very, very slightly, but its resistance will change. And these are very, very, very small changes in resistance. And require some reasonably sophisticated electronics to detect that difference, amplify it, and then display it. But strain gauges can be made extremely small, And the transducers that we use these days are generally made up by manufacturers as disposable kits, complete all the plumbing, the various bits of tubing, taps, and flush devices and so forth that are needed. In the past, the transducers were much more expensive. They were reusable, and they were generally plumbed together using an ad hoc arrangement of taps and tubing, which was certainly not ideal. So there's a strain gauge, greatly magnified, and you can see that zigzag pattern of a foil on an insulating, flexible insulating diaphragm. And the two leads at the bottom, the two gray leads, are going out to the outside world to be measured, or at least for the current systems to be measured. So we will require some cannula inserted into an artery, and the design of this cannula is fairly important. If you recall, it's going to be inserted into the artery and left in for, you know, several days, maybe at a time. It needs to be short, it needs to be narrow to reduce damage to the artery, parallel-sided to try and ensure that flow is as laminar as possible, and preferably made of some sort of material to discourage thrombus formation. Thrombus formation is, of course, less likely in an arterial system than it is in venous, but nevertheless, it's still possible. It should preferably not have a port on it to reduce the risk of arterial injection, which is always there because we have taps, but at least if there's no port, it's not as tempting to inject something into the artery. We then have a fluid-filled tubing to transmit the waveform to the pressure transducer. And we need to consider, and we will consider in another couple of slides, we'll be considering damping, resonance and damping. So we've extra three-way taps and unnecessary lengths of tubing that need to be avoided. Again, this is to do with damping. I'll come on to that later. And we need to be very careful, obviously, with the taps, that they aren't left open on the patient side, because it's an arterial system, so blood will leak. The electronics to convert the transducer resistance changes into a waveform then need to be able to display the waveform accurately, display a numerical waveform. They probably have some means of zeroing and for calibrating, and there will be additional modern machines will have additional features such as alarms and data storage and trending and that kind of thing. So here is a typical transducer setup. You see the tubing on the right hand side is described as being non-compliant. It's a fairly stiff walled tubing. You can see it's got a blue, this one's got a blue stripe on it, which points out that it is actually different from just ordinary medical grade tubing. And the transducer sits in the middle there, and there's a fast flush device just to the left, which allows you to flush through saline or dextrose or whatever into the artery. The tubing on the left hand side goes into a bag and is pressurized to high enough pressure that it will always be able to overcome the pressure in the arterial system. Okay, we mentioned resonance and damping. Now, as I say, one of the great things about intra-arterial or intravascular pressure measuring is the waveform. It's diagnostic as much as the digital output is. So, thinking about resonance, everything in the natural world has its own natural frequency. If you think about guitar strings, you think about a bell, think about a wine glass, you tap it and it rings at a particular frequency. And whilst resonance is great for musical instruments, it's not so good for transducer systems because if the diaphragm resonates, it will produce its own waveform, and that's not what we want at all. So kit manufacturers produce their systems with very much higher resonant frequencies than expected cardiovascular frequencies, which would be a maximum of about 3 Hertz. Even so, a diaphragm left unchecked is still likely to oscillate. Having been hit by an arterial waveform or arterial impulse, the likelihood is that it will begin to oscillate a little bit. So in order to combat that, we introduce the concept of damping. Damping refers to the reduction in energy of any oscillating system. If you think the child's swing, we have friction at the pivot points, and it is that friction which damps the oscillation unless you push some energy into it. So left to its own devices, our measurement system would oscillate with each waveform, with each pulse pressure waveform. It would swing up past the correct peak and then begin to oscillate on the way back. So a little bit of damping is introduced to ensure that it just rises to the peak and falls away. A lot of mathematics involved in this. I don't want to get into that at all, but we have to consider that there are 4 conditions for damping. There's critical damping, where the system shows a waveform which rises to its correct peak and then falls away back to its baseline. There is overdamping, where it never actually rises to the peak at all. Underdamping, where it overshoots and then bounces a little bit. And then there's what we actually are looking for, which is optimal damping. Optimal damping is where you have it slightly underdamped, so that you have a compromise between a rapid rise, which is what we want really, but it doesn't overshoot. So that's optimal damping. Unfortunately, optimal damping can be very quickly and easily turned into overdamping by bad practice, basically. The introduction of more 3-way taps introduces turbulent flow. Air bubbles are compliant in comparison to the liquid blood and the liquid, the fluid path. And clots also introduce turbulent flow. Arterial spasm, turbulent flow. And of course, as we know, turbulent flow is a very inefficient kind of flow. It doesn't obey the Poiseuille-Hagen formula. Right, which leads on to flow, actually. So what is flow? It's a measure of the volume of fluid passing in unit time. Okay, and we're familiar with the idea of laminar versus turbulent. Laminar flow is what we like to see in physiology. It's a very efficient form of flow where pressure and flow are directly related, whereas pressure and flow are certainly not directly related in turbulent flow. So we know the factors that affect turbulent flow. The Poiseuille-Hagen formula gives us pressure, length, cross-sectional area, and viscosity, of which, as every student knows, cross-sectional area is the most important. And you could say that the simplest way to measure flow is to collect all the volume in a container and measure it over a certain length of time. And that gives you a flow. Accurate, yes, but somewhat impractical outside of a laboratory and a laboratory animal. Measuring flow is a very much more difficult thing to do than to measure blood pressure. And because of that, there are lots and lots and lots of ways of measuring flow. but really only a very few actually interest us in anesthetic practice. The two traditional techniques for measuring cardiac output have been dilution and thermodilution. Unfortunately, although accurate and very useful, they have come under some review recently, and it is felt that the benefits obtained by these techniques, given that they require catheterization of the right heart as well as the pulmonary artery, the benefits do not, in fact, justify their use. So other methods of injection techniques have been developed over the last few years. Injecting lithium into the venous system and measuring the concentration in the arterial system has been developed using a lithium sensitive electrode. The benefit of this is that you can use peripheral veins and peripheral arteries to do the job. One of the problems with it is that it does extract arterial blood at a rate of 4 mils a minute. So there may be a potential problem there. PICO uses a combination of pulse contour analysis. Now, pulse contour analysis is a highly mathematical technique which looks at the waveform. So obviously you require a good arterial waveform, properly damped, as we discussed earlier. So it's a combination of pulse contour analysis and thermodilution. But the inject date for the thermodilution is actually into a central vessel and not into the atrium, which would be a considerable benefit. The technique obviously requires an arterial line and a central line, but if you're going to be performing PICO or any kind of cardiac output analysis, I think it's fair to say that you are going to have an arterial line and central line anyway. And as stated, the arterial waveform, the quality of the arterial waveform becomes very important. Ultrasonic flow meters have been around for some considerable time. If you think back, the early days, ultrasonic flow meters were used for looking for deep venous thrombosis, for example. So ultrasound, sound waves above the hearing range of humans, way above 20 kilohertz. If we forget about transit time flow measurement, Doppler shift is the technique that is generally used. And of course, Doppler shift relies on the change in frequency that occurs when an object moves towards or away from a waveform source. So something like an ambulance or a fire engine with a siren going, moving away and moving towards you, you perceive a change in frequency. To use it, the flow meter requires something to reflect the sound wave. Water, for example, or homogeneous fluid won't work. It needs to have something suspended, and of course, blood has the blood cells. Now, these were originally used just to measure flow, but they can be used to measure cardiac output as well in a relatively non-invasive way by embedding an ultrasound probe in an esophageal probe. So the esophageal probe is passed until it is opposite or adjacent to the descending aorta, and it then measures flow in the aorta. Actually measures velocity, but knowing the cross-sectional area of the aorta gives you flow, which you can interpret then as cardiac output. The problem with that, of course, is in terms of accuracy, is that we're making compromises in terms of the assumption of the diameter of the aorta. But a nomogram is used to supply the aortic cross-sectional area based on age, height, and weight, which is probably a very reasonable thing to do, in fact. So there's a esophageal probe. The problem with these things is, again, they're very operator dependent, and even the same operator passing the probe on different occasions in the same patient can get different results. So that was a fairly rapid whistle-stop tour of some aspects of cardiovascular monitoring, and hopefully basically has given some food for thought. Thank you for your attention.
Thank you, Dr. Philip. So now we'll be moving on to the discussion round. We have with us Dr. Kuchela Babu. Sir, please unmute.
Good evening. I welcome my co-chairpersons. I congratulate Dr. Kodali Bhavani. As usual, extensive, well informative, evidence-based, recent advances and what is the future of capnography is highlighted about the landmarks happened since 30 years. As usual, the capnography not only uses in operation theater, outside the operation theater is the most important in ICU and also CPR. Especially anesthesia, not only using in operation theater, especially in pediatrics and also the pregnant woman. He extensively discussed about what is the role of capnography in ICU. These few words, thank you very much, sir. You have given a wonderful talk. I am searching for any
So far, no
charts,
questions.
no
And
questions from the audience.
Yeah, we have Dr. Dibendra Tripathi.
1 minute. Yeah, 1 minute. 1 minute. I will have one question.
Yes, sir.
Dr. Bhavani, sir. What is the role of capnography in fluid challenge in ICU septic shock patient? That is, recently evidence shows that it is an also a dynamic parameter to monitor the fluid responsiveness. What is the physics behind? What is the physiological physics behind it?
Bhavani sir, you are not audible, sir.
Sir,
You are
Bhavani
not
sir,
audible.
you
are on
unmute,
mute.
unmute, sir.
No,
Bhavani
he's
sir,
unmute, but he's not audible.
unmute now. He's yes.
Yeah, can you hear me now?
Yeah.
Yes,
Thank
sir.
you. Yeah.
Okay, good. See, you are absolutely right that recently there has been a thrust to use capnography for fluid management in septic shock. The physiology behind this I already explained. The CO2 production or the CO2 applied to the lung elimination is a product of CO2 production as well as the CO2 distributed to the lung. So whenever the cardiac output increases with fluid management, naturally you are getting the CO2, your cardiac output to the lungs increases, and therefore the CO2 elimination increases, and that actually gives an idea that the patient is actually getting better with the volume response. So that is the fundamental basis of using capnography in this septic patient.
Okay, sir. Thank you. Thank you very much, sir. Now, unmute the Tripathi.
Yeah.
Yeah.
And we have Dr. Bande sir also joined us.
Yeah. Dr. Bala Bande.
Very good evening, and I thank the organizer for giving me opportunity to participate and listening to the two wonderful speakers. And I have been listening Professor Bhavani Shankar sir since my student days, and every time I listen it, and it is a pleasure for me. And I have one question, sir, and that is what is the significance of the time delay in the measurement when we use mainstream capnograph versus a side stream capnograph, particularly in the context of a volume capnograph, which you have highlighted today's talk, and it is going. I believe it is going to be future of capnograph. It should be commonly used. But I have a little doubt regarding mainstream versus side stream measurement.
Yes, you're absolutely right. The mainstream capnographs are actually instantaneous. That means they are real time. Whereas in a side stream capnograph, because the CO2 sample has to reach from the patient's airways to the monitor, there is a delay. That's why in our operating rooms, when you are using the time capnogram, there is always a little delay. But it is only a second or so because it doesn't take too long for the gas sample to reach the monitor. Now, the recent technology which actually I showed you, it uses a side stream capnograph but gives you a real-time images. The reason how it does it is they have incorporated the delay time into the software. So you actually get a volume capnogram using the side stream technology. That is why previously all volume capnographs are the mainstream sensor. That means because you need instantaneously the flow also, correct? When you measure the CO2. Whereas the newer version of the side stream capnography that also gives you the volume capnogram has a built-in software to correct for the delay. So the side stream capnograph is as good as a mainstream capnograph to measure the volume capnographs and physiological dead space. But you're absolutely right that currently available technology, most of the volume capnographs are the mainstream technology.
Okay, sir. Thank you, sir. If I may ask one question to Professor Philip also. Thanks for the wonderful talk, sir. But I have one query regarding that semi-invasive or less invasive techniques which you have highlighted in your talk, and there are some technique which is coming up as a purely non-invasive technique for measuring cardiac output. But how far it is the accuracy level and the practical means when we are interpreting the values, cardiac output values, when we compare it with the standard of care, the gold standard invasive cardiac output monitor. There are many studies, but I just wanted to have your expert opinion regarding this. Can we purely go on, it is time to switch over to the less invasive or non-invasive technique?
Well, I think the current studies have shown that the risk-benefit analysis shows that using very invasive techniques, such as the cardiac output catheters, does not have a significant positive effect on outcome. So any other technique which can provide you with at least an approximation to your cardiac output has to be an improvement. Now, bear in mind that you're talking about a trend, so the absolute value is perhaps not as important as you might think. You're talking about trending, and in a similar way to your discussion just a minute ago with Dr. Vivani about the capnograph. Again, it's trending. The beat-to-beat cardiac output probably is not so significant if you're talking about fluid replacement. You're talking about a trend. Are we actually improving things over the last 5, 10, 15 minutes by giving fluid or not? So I think the benefit of a relatively non-invasive cardiac output measurement, bearing in mind that all of these measurements per force are relying on assumptions. So you're relying on an algorithm to give you the area of an aorta, for example, and you're relying on a number of assumptions, which all taken together probably mean that your actual value is not, in fact, correct. But again, you're looking at the trend. If the error in your measurement is the same each time you make the measurement, then the trend is what's important, not the absolute value. Does that
Thank you, sir.
Kind of answer the question?
Yes, sir. Yes.
Yeah, if there is no questions, thank you very much, Dr. Kodali Bhavani and Dr. Phillips Athwe, and other my co-chairpersons. Thank you very much. Given my wonderful talk by both of you.
Kuchala sir, there was one question.
Yeah.
Can you just elaborate more on use of EtCO2 in endoscopy, legal, and how to use and what are the limitations?
Yes, Kodali, this is a question to you, sir.
Sir Kodali sir, just unmute. Yes, sir.
Yeah. Can you hear me now?
Yeah, yeah.
Yes, sir, loud and clear, sir.
Okay. Okay, good.
The legality.
Yes. So the question here is, in United States, these are standards of care. That means if you are not using a monitor, a CO2 monitor during sedation, it is considered as a care below the standard. So there are legalities, involved here. So the question comes is, whenever there is a lawsuit, the first thing they see is it below the standard of the care in a given area? Now, I'm not sure if in India it has, whether the societies have enforced this as one of the requirements. If it is not enforced, even then, the lawyer can say that could this have been prevented if you were using some other monitor, and the answer is yes. So it does show that we have not actually matched up to the a good care in a given patient. So it actually varies from patient to patient, and even now I'm not sure whether the Indian Society of Anesthesiologists have implemented capnography as a standard. So that is why the rules may vary, but certainly in many countries, it is considered as a standard, and if its CO2 is not used, it is considered as a substandard. And to give you another important thing, even the dentists in the United States are supposed to use capnography now, because there were some catastrophic incidents in children having dental procedures and having died. So it is getting to that level, and that is why the pediatric sedation capnography is also taking an important role here. So it depends upon the region where you practice. So that would be my answer, and maybe Dr. Kuchel Babu can tell, because he's in the ISA.
Sir, thank you, sir. Definitely, it is already ISA is endorsed, sir. It is a standard monitoring for the capnography in anesthesia. Wherever the patient is anesthetized, the capnography is a mandatory.
Right, but what about sedation? I think his question is,
deep sedation. It is under deep sedation, under the whatever the till now we have come out with our guidelines. Only the standard monitoring the operation theater. Outside the operation theater, still we didn't come out as ISA. But who are under deep sedation, it should be the answer is yes. Under deep sedation, yes.
So I think in summary, the legal wise, you may not be penalized because it is still not a standard, but you may be liable in one way that yes, we could have improved our care by doing that.
Sir, one more thing, sir. Whenever what they will ask is the legality wise, if the equipment is available, if you don't use it, 100% is a negligence comes. Wherever used in the hospital, the equipment is available, you don't use it. Not only the standardized, it is in the literature says, any evidence says, even the books, they'll quote in the court of law, not only the standardized. If in the book or a textbook or a journal says, they quote the defense lawyer, they will say it is a standardized. In outside also, if the available the equipment are to use, definitely it is legalized, it is a punishable offense.
Okay, that's good to know.
Okay, sir. Thank you very much. Dr. Balabande, he joined, Dr. Balabande?
Yeah, that the question was from him only.
Okay, thank you.
Okay, I think any more questions? Dr. Dipendra sir, any questions, sir?
Yes. Unmute. Okay, sir.
Okay, sir. Thank you. No more questions, sir. It was very clear. I thank.
Thank you.
Thank
Bhavani
you.
Gare, sir. Thank you very much.
Thank you.
Thank you very much.
Thank you, Dr. Phillips.
Bye-bye.
Bye.
Thank you, speakers, Dr. Bhavani sir and Philip sir, for your wonderful time with us. And also it is our duty to thank on behalf of IS